I suggest we start with a round of introductions, and we want this to be a dialogue with you all anyhow, rather than talk at you for however long we take. I know this is scheduled for 3 hours. Don't know if all of you have blocked 3 hours in your diary, but the point is not to hold anybody here for a fixed time frame, but to have an engaging, a shared reflection. We have some things prepared that we will share with you, of course, but we very much want to do this all in dialogue with you all. And I think we'll start with introducing ourselves here as organizers, and then given our current size of group here, would invite all of you to briefly introduce yourselves as well, and just share about your current role, but also what you're interested in, and if you want to say a word or two about specific activities internationally, maybe as well. And then we can come back to more expansive discussion later on, at least, but that we will kind of know who's gathered, because I presume that some of you won't know each other, maybe some of you even do. So, let me kick us off. So my name is Stefan Wisbauer. I'm one of 2 managing directors here at Lecturio. My background is in math and physics, actually. I spent some time doing an MPA, Master of Public Administration, at the Harvard Kennedy School. I really enjoyed that. Spent some time at the World Bank after that, initiating some efforts around knowledge sharing between international development institutions, amongst other things. Something that's today called the Development Gateway grew out of my time there, and a proposal that I wrote. And I've been at Lecturio here since 2013, so it's been a while, and look after our global institutional work. And one of our interests there very much is capacity building in low and middle income countries, and doing that in innovative, scalable, high quality ways. We'll obviously talk about that in more depth as we go through all of this. But this is not a Lecturio marketing event. We have prepared some generic reflections on the challenges for you. We want to hear about the solutions and problems that you've been facing, what's worked, what's not worked, and so on. And we'll also be sharing, obviously, about our own experiences, and we have a range of that to share. So that's kind of me in a nutshell. And I would say maybe Sanja, do you want to go next?
Sure. Hi, everybody. Warm welcome from my side. I am Sanja Sontor. I am the Director of Development Partnerships at Lecturio. I'm responsible for our projects and capacity building efforts in low and middle income countries around the world. Also responsible for building relationships with our key stakeholders, whether these are ministries or multilateral organizations. My background is mostly in the development sector, but on the non-for-profit side, and I kind of spend most of my career working in education. I'm very much looking forward to the session, and I can just echo what Stefan said. We want this session to be stimulating for you. We want to hear your thoughts, and not really being us only speaking, but hearing your thoughts, hearing your experiences when it comes to medical capacity building. This is all from my side. Maybe to Dr. Hornefer now.
Thank you very much. And so I'm Dr. Peter Hornefer. I'm Director of Medical Education at Lecturio. I wear several hats, actually, and I'm also the Executive Dean of the All-American Institute of Sciences in Jamaica, which is an innovative medical school which was created to increase capacity in an underserved part of that country. And we'll talk more about that in a few minutes. I'm based in the United States, in the state of Maryland, where I landed to go to medical school at Johns Hopkins a number of decades ago, and actually stayed there and trained as a cardiothoracic surgeon, and practiced for many years as a heart surgeon, and went into heart surgery at the time was the dawn of the heart transplant era, and one of the most exciting things I could think of. And it remained so till about 15 years ago, when I was asked to use something that it seems hard to imagine now, but seemed quite new at the time, called the internet, to bring education to underserved areas. And I thought that that sounded like a radical new proposition that I would be interested in being involved with. And we started in what I believe was the first ultimately accredited hybrid medical school, one that had its didactics brought in online and established a school in Samoa, in independent Samoa, but also educated students in Australia, New Zealand, and the United States. And I came away from that thinking that that was even more empowering and exciting than heart surgery, and went off to find an ed tech partner to help grow this vision and globalize and really democratize the availability of high quality education and use digital resources to do so, and had the great fortune to meet Stefan Wisbauer and his colleagues who were headed in the same direction. So we joined forces several years ago. I still have a small oversight responsibility in a couple of hospitals that have heart programs that I helped initiate, but 90% of my efforts are now divided between developing Lecturio's platform and ensuring that it remains evidence-based as our practice in medicine is. And we'll talk a bit more about that, I know, in this session. And then I also am creating this school. It's actually fully functional, but helping evolve the school in Jamaica. So that's my profile. Very pleased to be here, and hope we have a very interactive discussion. So thank you.
Thanks, Dr. Hornifer. And in terms of the interactivity, I would say we start straight away. And I was just trying to study the algorithm by which Zoom sorts the participant list. And I think being unmuted like Dr. Rosenfield or John Rosenfield, there is one criteria. So maybe you want to kick us off, and please just say hi and who you are and what your interests are. And then we'll go down the list here. I think it'll be interesting for people to know who's in the room here.
Sure. My name is John Rosenfield. I'm a retired pediatrician, and I had 18 years of specialized training in the interpersonal development of infants. And after I retired from my private practice of 31 years, where I was in solo practice for the entire 31 years in a small town north of Columbus, Ohio, I was able to participate in a lot of engagement in helping parents with their infants. And I was trained particularly during my residency in child-centered health, which I think is important. But as my specialized training went on, I became more maternal or motherhood centered in my practice. I found that by helping out the what I call the motherhood constellation, which is a series of relationships rather than a single person, which includes the father, of course, I found that it was more helpful to infants. And my reason for my interest in digital healthcare is that I'm looking over the rest of the century of what healthcare is going to become, including virtual types of assistance. And I see that as a promising opportunity to make what I know in interpersonal development in infants available beyond just this country on a more global level. And so that's an area that I've been doing a lot of research on as well.
Thank you, Dr. Rosenfield. Excellent. Interesting parallels if you think about finance in developing countries, you know, sort of the mothers creating small businesses with microloans has proven a very efficient way. And I'm sure the mothers in the developed country settings can also be a high leverage point for interventions of various kinds. And Dr. Davis would be next on the list here.
Hi, everyone. Happy Wednesday. My name is Takila Davis. I'm an information systems doctoral intern assisting with Northwestern University under Dr. Melissa Simon, working with the health equity. Mainly, I'm here to learn and I want to listen, but we focus on the lack of healthcare and the lack of the social detriments that urban communities are facing is what my study is focusing, because I focus on information systems. I want to advance and enhance the data that is lacking, but most importantly, the lack of artificial intelligence. We notice every day that technology is taking over from our phones to our computers, that we don't even have to go into the office anymore. So I want to learn how to provide those communities that don't have that technology or cannot afford those systems to have the information, even if the numbers aren't matching, but to provide the data that is needed. Thank you.
Thank you so much. And certainly the connection between educational data and then translational research into impact in the care setting is something that we find very interesting. We can come back to those aspects. Dr. Charles, Carolyn. If you can unmute, you would need to. And if you prefer, you can also just write in the chat here, whether technically or otherwise. You might not be in a quiet setting, you know. So no obligations here. Dr. Murphy, would you like to introduce yourself briefly?
Yeah, Kelly Murphy, Associate Professor of Medicine at Stanford University for the past 29 years. Have worked extensively in Papua New Guinea and Nepal doing remote medical education projects. And currently with COVID, we're kind of trying to look at other alternatives to be able to do our work.
Excellent, very exciting. Looking forward to hearing about all your experience there. Dr. Martin?
Hi, thanks for holding this satellite session. My name is Marie Martin. I'm with the Vanderbilt University Institute for Global Health, where I direct education and training programs. We work globally in a number of different settings, but in particular, I'm engaged at the University of Liberia, which the medical school has just recently adopted Lecturio. So I have some dual interest here, interest in education more broadly, and using platforms like Lecturio to really harness the potential of resources outside the country to build capacity, but also uniquely interested in maybe how we can think about that in Liberia as we continue to enhance the curriculum and opportunities for medical students to access, you know, information that they need to be successful.
Excellent. Well, that's great. And it shows how interconnected the world is. Right here, you are from Vanderbilt, connected to our project in Liberia, which is funded out of Yale, by the way, you know, and different efforts in different parts of Africa. We have different funding partners. Some of them are funded by the local partners in Rwanda, for example, but they then in turn have funders behind them. And, you know, I certainly believe that interconnecting stakeholders and sharing knowledge and so on has a lot of potential, especially for making things more scalable within the systems, because often the digital foundation is just, you know, it's that foundation, and what can you really do with it and achieve with it is a separate question of change management, accreditation, and everything else. And also, frankly, people working together that don't always historically work together. Dr. Jennings, please.
Hi, good afternoon, everyone. My name is Natanya Jennings, and I am a medical lead of what BMS calls the Global Health Equity Platform at Bristol Myers Squibb Company. So my remit, I mainly focus on low and middle income countries for which we don't at present have a registered footprint. And I'm just very interested in learning from all of you today. I've not heard of this company before, so I'm super excited and pumped to hear the innovation that will come through this conversation. Appreciate it.
Thank you so much. And I think that takes us down the list here, if I'm not mistaken, unless anybody who I called on before wants to jump in now. Feel free to write in the chat as well, as I said earlier. And Sanya, are you going to kick us off in terms of the first sequence of materials here?
Yes, I will. Let me share the screen. I hope you are able to see it. Okay. So let me just move the boxes and hopefully everything can work. Okay, well, I will kick us off and I will talk a little bit about just setting the scene. I think it's very important. I mean, I've noticed we all come from well, you all come as an audience from different perspectives and different experiences. And I think it's very important that we kind of set the stage a little bit in terms of what are we kind of focusing on and from which angle we are approaching this topic. So it's very important to start talking about what are the key challenges that we see from our perspective when it comes to medical education in low and middle income countries. I believe that most of you would agree with me that COVID-19 pandemic has really brought the porousness of the global healthcare systems into the focus, and not only in the developing countries, but also in the developed countries. And the access to healthcare and as well as medical education and training has never been more important. Yet the World Health Organization is talking about huge deficit in the labor market of trained medical experts and professionals, currently standing at 7 million, and it's about to increase by 2030 to 18 million. Let me see. When we talk about the distribution of the healthcare workforce, I think this is actually provided by the World Health Organization. We can see that the distribution is very uneven, very disproportionate, and what comes into the focus is probably African countries in Southeast Asia, where there are actually less than 2 doctors in some of the countries, less than 2 doctors per 10,000 people. To put things a little bit into perspective, in Germany currently, I was just looking at the most recent statistics, there's 1 doctor per 200 people, and the World Health Organization recommends 23 doctors per 10,000 people. So the problems are pretty severe in many, many parts of the world. Well, one could argue, well, we could kind of offset the issue of lack of healthcare workforce around the world by simply enrolling more students into medical schools. If it was that simple, as the slide suggests, that there are a lot of limited educational opportunities for the future healthcare professionals. Again, what strikes us is African countries as well as Southeast Asian countries, where there in some cases less than 2 medical schools per 10 million population. In Africa alone, there are 168 medical schools. 24 countries have only 1 medical schools, whereas 11 countries have no medical schools. So we are really talking about a very severe issue that cannot that easily be offset by simply enrolling students into medical training facilities. When we kind of overlay one more extra layer of the complexity, which is the distribution of rural versus urban population that has no access to healthcare due to the healthcare worker shortages, I like this slide that was prepared by the ILO that actually showcases again discrepancies that exist between rural and urban areas. What strikes us the most, again, as I talked about Southeast Asia and Africa, again, being part of the worlds where discrepancies are the biggest. So in Asia and the Pacific, excluding China and India, if you look at this part of the graph, there's 75% of rural population that has no access to healthcare. And in Africa, that number is 77% that don't have access to healthcare due to the lack of healthcare professionals. In the same regions in Asia and the Pacific, excluding China and India, only 27%, well, actually 27% of people don't have the access to healthcare in the urban areas. And in Africa, only 50% have access, so don't have access. So the number is really, really staggering and very complex. Once we overlay this issue with the estimated population growth projections, this really brings and shows urgency for action. So again, focusing and narrowing down a little bit more in sub-Saharan Africa, Central and Southern Asia, and Eastern and Southeast Asia. These are again regions where projections are showing the highest number or highest growth in the population in the next 80 years. And simply this issue cannot be solved very easily. That's why we believe there is a need for new methods that require different kind of thinking. And one could argue, well, there could be a way that we could tackle this, but all with infrastructural capacity building. So essentially building brick and mortar medical schools around the world. But that can really only partially tackle the issue simply due to the predicted population growth in many countries around the world. And plus, we're talking about a solution which is not scalable, it's very expensive, and it's not really flexible. So from our perspective, what is very important is laying this digital foundation, a strong digital foundation across existing institutions based on which the whole system interventions can be built in Africa and around the world, and most of the low and middle income countries. As the title of the session suggests, we're not only talking about physicians and medical doctors, we are really talking about the whole spectrum of medical staff, whole spectrum of medical workers. So we're including here physicians, doctors, nurses, community health workers, which are a backbone of a workforce in many African countries. And fundamentally, we're talking about capacity increases that can happen not only regionally, but also on the national and international level. So when we talk about medicine and nursing, we are talking, of course, about systemic support of national universities and schools through kind of three-folded approach. Digital teaching engine and apps that can allow this flexibility of reaching and pulling the materials whenever it's needed with low and no bandwidth situations where, for example, content can be accessed offline. Then we're talking about local content production because it's very important that the content reflects the realities and the needs of the population on the ground. And then online simulations that can provide that practical aspect of learning, also very much important for both medicine and nursing. And finally, besides the pre-service kind of trainings, we can also consider in-service personnel training for already practicing doctors and nurses. Like I said, community healthcare workers are very important ingredient to a lot of labor force in the African countries such as Nigeria and Ethiopia. And here we can talk about similar kind of trifecta of services that can be offered to increase the capacities. Again, we're talking about pre and in-service training offered through digital teaching engine and apps, local content production, and online simulations. In the end, what I believe this will create are essentially capacity increases that do not happen only on institutional level or regional level, but these can happen on national and international level, and really seeing a country as an education hub. I mentioned that, like I said, I mentioned digital foundation. As I said, this is what we believe is the fundamental layer based on which the wider systemic approach can happen. And why we believe that is because we can create rapid gains in effectiveness through that and real capacity boosts. And based on the solution, which is scalable and flexible and pretty affordable, we can think about other aspects that can enable wider systemic approach, which is also distance education. We are talking about solution, like I said, which is scalable, decentralized. It can be linked to a digital platform, and it can be combined with clinical rotations and simulations. We can also build on that by building replicable rural clinic models, which are relatively affordable and quick to establish. They can have telemedicine support, be enabled, and then receive rotating students. And kind of final piece to the puzzle would be those regional simulation centers, which can be done very similarly to how airline industry is doing, very well equipped. They can have rotational again of students, and these don't have to be necessarily built in a country or to serve a specific institution, but rather have an approach which is more multi-country and shared. So here I would conclude. Like I said, I wanted us to introduce us to the topic, a little bit setting the scene, and now I'm giving the word to Stefan, who will talk more about the key elements of the medical education capacity building and then accompanying challenges. Stefan, maybe you want to share your screen.
Yeah, let me do that. In terms of timing, makes it easier. So let me find the right one here. So I just have to check if it works then with the full screen as well when I do that. Is this rendering full screen now? I think so, right?
It works, yes.
Excellent. Good, good, good. So the bunch of challenges, obviously, and when I realized, Sanja, we haven't included much in terms of what we're using to deliver these things, the interventions that we're trying to facilitate. What we're going to do is go through the fundamental challenges we see in a structured way. They include, obviously, how do you deliver the medical education? And by systems, we don't just mean empty shells and LMS systems and things like that, but obviously there's if we're talking teaching system, then there's a very significant content component to that. Nevertheless, to deliver modern blended interventions that might loop in rural areas more effectively, et cetera, there is obviously the hardware aspect as well. And finally, there is the internet access aspect as well, which is a potential blocker for making these things efficient. So we'll go through this in a structured manner and talk about them both generically as problems and also hear your own experiences as we go through that, and then at the same time share a little bit about what we've built to try and facilitate these kinds of interventions. Let me kick us off here, and let's talk a little bit about delivery systems. This has been interesting also as part of the COVID interventions and the need for capacity building there. There's been a lot of different platforms hosting content, and you can send people to them. But as in medicine, where you actually want to take a measurement of your patient, get feedback to then optimize and so on, that's something that's often missing there. But at the same time, it's obviously great news these days that an amazing amount of educational material is freely available. So today, if my kids want to learn something, I have two daughters, the amount of information they can find to do that online is staggering. Unfortunately, of course, they spend much more time watching entertaining things that they find fun, cute dogs and what have you, which cheer me up as well from time to time. But just the availability of these things is staggering and across all of the basic sciences, but really over all the way to, if you think about Coursera and things like that, to very, very advanced things like machine learning and all the things I can go and learn online tomorrow. But when you're doing capacity building, obviously it's not so easy to, how shall I say, to declare victory or an achievement if you can't really track what people are doing and understanding and so on and so forth. So one of the problems with these open systems is that, you don't get feedback. You can't control what you can point them to things, obviously that way you can curate a little bit. But it's not proper teaching cycle, with feedback coming back to you where what the activity was, what's understood, and so on and so forth. And I'll come back to how we're trying to tackle that as part of what we do. And then there's a lot of systems out there, some of which pretty powerful. Moodle, obviously, well-known public example. And then it's easy to sort of get excited and say, oh, that's open source, that's fantastic, because open source will basically be free for us. But if you spend any time in technology and trying to get a teaching system together, that then you have to host it and you need a technician and then you need to tweak it. And then it's empty to start with. So still a very, very long journey and potentially a lot of expense ahead, especially to teach a complex subject like medicine, and whether that be at the doctor level, at the nurse or the PA or the health extension worker or community health worker, as they're called in some places, etc. So it's easy to, how shall I say, kind of to jump on a technology, but the technology as an empty thing in its own right, is only a piece of the puzzle. Any kind of LMS, even if you take an advanced one and frankly also expensive one, Moodle, Blackboard, etc., have the same challenge. Or even Google offers you a lot of things for free actually these days, right? So you can use Google Classroom and start to populate it with things and so on. But to really deliver a nursing degree or a medical degree online, or to support the education in a given teaching institution in a given African country like Liberia, this is far from obvious and only a small piece. From our experience, what strikes us as important is that whatever setup you create, that it's really important that there is local control, So Marie mentioned our project in Liberia, so the University of Liberia has a dedicated system that they control. We have all our content on it, and we'll talk more about that in a bit. We've built a very comprehensive content base. But I'll come back to that. The fundamental point here is if you point them to a WHO Academy or to YouTube or to something else, the learners are kind of lost out there in the ether. And whether you're trying to train students to become nurses or doctors, or whether you have a workforce in a hospital that you're trying to get to roll out a vaccination program and manage a cold chain and whatever else, you need that feedback, you need that control of the system, such that you know who's done what and who you need to pick up the phone to and who you might need to visit and so on and so forth. And that seems sometimes forgotten. And we're having those conversations with WHO, et cetera, as well. And they recognize the need for systems that are locally controlled, and one of those aspects obviously means that they can add their local content because they have a different reality, they have different guidelines, they have different disease profiles, everything else. And part of our project in Ethiopia, for example, is we're producing equipment use and maintenance training for local nurses and biomedical technicians, and doing that in partnership with local technicians on the actual pieces of devices that they have available, to really make sure that it meets their needs rather than coming from some generic, optimal world, which leaves them well trained to operate in a hypothetical reality that they're not facing, but unable to deal with the actual pieces of equipment and things that they have available. This tracking and assignment point I've pretty much already made. If you're trying to teach people from a distance or in a blended manner or do capacity building in a hospital, you need to know whether those nurses have watched those videos on hygiene, whether they've understood them, ideally also whether they feel confident about their learning there, so that you can then decide how to further support them or not, and assess what might be limiting factors and so on. And that whole notion of adaptability of the platform, because you might plan some theoretical invention, along comes COVID, or along comes some other problem that reprioritizes things, and then you need to be able to adapt your local delivery platform to those realities. So that's a fundamental point there. So when we talk about our work in Ethiopia, so that means, each of the 25 medical schools that we support in Ethiopia together with the government and the GIZ have their dedicated system that they control, and we put in the national curriculum because they have one, but it's not easy for them to roll that national curriculum out to all of the schools because, like many places in Africa, shortage, therefore a lot of students get sent to those schools. Not enough professors, junior professors, quality issues, and they will openly talk about those things. But having a system that they control means that there is the local curriculum in there. Not all the schools might be using it, so each school can therefore put its own curriculum and has that degree of control I was just outlining, And on this local content production, here's just an example of how we then work as, kind of instructional designers together with the local experts to record these things. And the screenshot you see on the left here, it might not look like it, but this was in essence recorded with a smartphone camera and an influencer ring in terms of lighting around it and a very basic green screen behind it, and then edited by our team afterwards, and you will agree, that looks and ends up looking very professional, but it doesn't have to be expensive if you know how to combine the right kinds of technologies, and you can coach them, assist them, send them the right kind of hardware, etc., to do all of that. That's just to make it a little more concrete, this sort of abstract point around the local content. And then on the tracking, here's just a sample shot from the system, how you can watch, activity, track understanding, track confidence levels in different areas, have your different nurses on the right-hand side. This is probably a bit small for you to read, but in the COVID context, for example, you could, put hospital managers, nurses, intensivists, local church officials even, and they would each require different kinds of contents to manage that intervention. But if you have those groups and you have that system you can control, then you can steer that out to them and you can track and manage it, and you have an actual intervention. So first point of pause here in terms of discussion, we'd be curious to hear from you as well. What delivery systems have you used in your efforts? Some of you mentioned you've done some extensive work already, and how has that worked for you? So feel free to just unmute and share.
And Stefan, may I come in for a minute?
Of course, anytime, Dr. Horner.
And just to add, and I know the focus is sort of on the technical delivery and the systems, but from my vantage point in academics, one of the very important concerns we have is the unedited or uncurated, you alluded to the volumes of information out there, but in the historical context, you could only be referred in my day to textbooks which were edited, reviewed, and were understood to be credible sources. Now there's a tremendous amount of information that you really don't know how credible it is, and our students will go to this. So another inherent part that's not exactly what you were referring to is having well curated and overseen and edited sources. So I think that's important. And then the other big challenge that there's so many tempting places to go and so many sources that students are spending a lot of time going between different sources. And there was an interesting study not long ago which compared the academic performance and to the number of additional outside of their school sources that students were using. And actually the best students were only using a few sources versus, shopping broadly and going into all sorts of different areas. So I think these are also important concepts to keep in mind, not as one focuses on a delivery system.
Thank you, Dr. Hornifer. Anyone who wants to share about systems they've used, whether mobile or LMS or others, to drive interventions, and how has it worked? And if you like, if people haven't got much to share there, then I'd be happy to show you very briefly, since Dr. Hornifer mentioned the content side of things, just what we're leveraging in our efforts in Ethiopia there. There's a lot of content needed, so in terms of the system that we've built, it's been a global collaboration, and faculty from Harvard, Yale, Hopkins, Brown, UCL, Imperial College, many others, and really in the spirit of creating something that is consistent and safe, but also tailorable to the local needs. Therefore, a lot of different curricula available here, and they then get tailored to the local environment. Because in the US you have a 4-year curriculum, in many other places you have a 6 or 7-year curriculum, and then very comprehensive content-based, both theoretical videos. I'll show you a brief example here, since we have pediatricians on board. Let me take the nursing level very briefly here, and talk about pediatric nursing. You can see here some 150 videos. Infectious diseases, always a big topic, obviously, in many low middle income countries. And let's just take conjunctivitis here, management complications. You'll see
how
these
do we
are
treat
then
pink eye? Well, it really depends on the cause.
Always short videos going through the key components here, and always trying to illustrate and make things memorable, etc. And then I'll just show you a brief second example here from the physical exam side on the doctor side. So these are then, very comprehensive physical exam skills, some 90 videos just on that. And so here, let's take examination of the abdomen and show you a very brief sequence here. This is Dr. Holt in the Yale Simulation Lab. And just play this for 10 seconds.
Remember that the aorta is going to come down here from the epigastrium. It comes down here to the umbilicus, where it bifurcates into your two common iliac vessels that are then, of course, going to end up going into your external.
You get the idea, and just to give you a sense of the scope of the content side that Dr. Hornifer was mentioning, we have about 10,000 videos in here, then about 30,000 quiz questions, which are used for tracking and space retrieval algorithms and things like that. One of the things we believe that in Africa, you can genuinely leapfrog in terms of education models, because they will more readily adopt the latest technology than, say, we do in Germany, where we're frankly slow to do these things. And so there you have a comprehensive textbook library in here, as well with articles on all all the key subject areas. So anyhow, but I don't want to turn this into a demo, but since we're talking systems and since nobody shared anything there so far, I wanted to share that briefly with you and then go back to the presentation. But also let me make room again in case somebody wants to share about systems that they've had experience and or problems with.
I'd like to interject a question.
Sure, please, Dr. Rosenfield, go ahead.
How do you intersubjectively relate across cultures, say with from Western medical personnel to African medical personnel and their patients?
Yeah, it's not an easy one. So so a number of things. So and I'll let Dr. Hornifer add to it here from also his cultural experience at Samoa and so on. So so firstly, we have a generic content base, obviously, for the world. You know, luckily in medicine, much of the content is relevant across the world around physiology or, you know, typical heart disease patterns, etc., with some variations, small vessel disease and amongst Asians and so on. So there are always these variations, but obviously there are much subtler cultural differences, right? So on the one hand, we emphasize selecting what is relevant as it is, right? And then structuring that to match the local content. Then in a second instance, looking at what might be gaps, so what might be missing or what might be different, and then co-producing those kinds of things. And we'll have some, this brief example I showed here. Oops, let me just go back to it. On the content side, you know, this is then very much produced for the local market with the local entity. And we're doing this right now, for example, with community health workers in Ethiopia, and very much, you know, with the guidance of the local health extension worker is the trainer for the local health extension worker, because they know best, you know. And that doesn't mean, though, for example, also in this example where we pick that local piece of equipment, that if you're talking about a ventilator or other types of equipment, oxygen concentrator and things like that, that we don't also then, you know, put the generic, you know, relevant bundles from physiology and whatnot underneath to lay the foundations for that. So it's really that effective mixing, tailoring, and joint local co-production with which we try to sort of tackle the cultural and other differences. Dr. Hornifer, anything you want to add there?
No, and I would add, and I'll allude to this when I speak later, one of the things that really opened my mind and interest in becoming involved in this area was when I traveled to Samoa, a country I'd never been to before. And I have to confess, I knew roughly where it was geographically, but not, I couldn't pinpoint it precisely, and was struck by the commonality, actually, that there was far more commonality in terms of approaches to patients and amongst physicians. And in some ways, so I was based in Baltimore, in a major metropolitan area, and then also started a heart surgery program in the western part of Maryland, a very rural, underserved area. And I would say there are probably as many cultural differences traveling from Baltimore to Western Maryland as there were in some ways being in Samoa and some ways in Jamaica. So as Stefan alluded to, you need the ability for individual customization, but there is far more commonality than differences globally. And this is greatly empowering when we're trying to reduce costs, to provide excellent education, when you can have lessons and didactic direct instruction lessons in a platform that could be widely disseminated repeatedly. There are tremendous efficiencies and an increased effectiveness that's appreciated globally. So that's my perspective from my actual travels and experiences.
Thank you, Dr. Hornifer. And let me highlight one other kind of localization component, because Dr. Martin just asked about clinical cases. And so let me just highlight there briefly one thing we've done, and this is localizing even like within the US context. So we have over 5,000-6,000 clinical cases on the platform, nursing, medicine, et cetera. They're all kind of clearly structured and so on. And and then these are kind of USMLE style exam questions at the same time, which are, globally used in so many different countries. That's more or less the exam format, including Italy, Spain, and so on and so forth, with small variations, Mexico and so on as well, and also becoming more and more of a standard. And so these are then, for example, unlike a video, where you do local production, I showed you the high effort version, these can be much more easily localized, and we have them with explanations, as you can see here. And we have some DO school clients, for example, these were made for general medical. And we just told them, look, you can duplicate this entire set, and then you're able to, kind of give it a DO touch, if you like, and in the same way, these can be duplicated and localized for the local context, because obviously different treatment options might be available, different mix of cases is coming in, etc. And luckily on those kinds of formats, it's a little less tech and production effort to get them adjusted.
But I would add also that we do have a lot of, we run through we have thousands of these video lessons, and especially in those that support the clinical years, we have case vignettes and scenarios that form the basis of teaching. So it's not simply didactic, and it really mirrors the process through medical school, that in the foundation years, it is more direct instruction, didactically focused, and in the clinical years, internal medicine and neurology and the various subsections of internal medicine in particular, we introduce many case discussions.
Thank you, Dr. Hornifer. So, okay, so if anybody else has comments on the delivery system side, please jump in, and hopefully some kind of useful reflections there around the local control, and at least we made you aware a little bit how we built that. But my key encouragement message would be to try and make sure you don't just give access and content to people, but you think about how they can control, manage, localize, etc. That's really important. So now let's talk about this interesting challenge of hardware. And Sanya, were you going to take this one? Am I taking this one? I'm perfectly happy to, so just checking.
Go ahead, Stefan.
Okay, so we've got some interesting illustrations here. Definitely not only the latest tech, the one in the middle looks reasonably modern, but there are obviously the different, the computing power has become so compact. I mean, the things that my phone can do today versus my Commodore 64, which is what my first computer with 64 kilobytes of storage space, and my iPhone here, I don't know, I think it's 256 gigabytes, and it's obviously tiny and very powerful and has all these sensors on it on top, etc. So there is a real transformation that's happened there. And if we think about low middle income countries, then that's, if we think about telephony in general, it's an area where they've leapfrogged. They haven't put in the landlines and the broadband lines in many places that we have. And I have one here in Leipzig, and it has a phone line. It's never been used, so just use my mobile phone, and so does my wife. And my older daughter has one as well, which presents its challenges at times. But but making content for those contexts, it's important to keep them accessible, and responsiveness is one important aspect there. And so in our platform, at least, we've made that responsive, but as and when you design things or pick systems, make sure they are responsive, because there's a high share of people accessing things through mobile devices. And so therefore, that makes it a lot more efficient. The other thing is affordability. Obviously, for the local salary standards, this is, might look a lot less affordable. But if you're thinking about interventions where these things can be challenges, and we're starting to work with a chain of 700 clinics in Kenya now, for example, but in most places, somebody in that clinic, or most people in that clinic, will already have a smartphone. But even if they didn't, the amount of extra budget you would need to equip them, each clinic, with a cheap smartphone or so, or a cheap tablet, would not be huge, and you can see the variation here in terms of prices, but the key thing to my mind is, what you can get for $100 these days, the kind of phone I buy for my daughter, because I don't trust she's not going to lose it or break it, is just amazing, and it's not so far behind my own personal higher end version, which luckily I didn't have to pay for, and so against the average monthly income, of course, that's a very different story. But nevertheless, I think that people see so much utility that at some point in their lives, early on, typically, they do what they can and try to get that smartphone, even though in the African countries it is a much higher share of a monthly income, simply because of the utility that you get. And obviously they last a while as well, if you're lucky not to break it, And so therefore, in terms of the hardware challenges, devising things that are simple and work across a multitude of devices is helpful. Looking at external financing programs can be helpful. You might get reduced costs by device manufacturers, bulk purchase and things like that. And, if we're talking health extension workers, it doesn't always have to be a smartphone. There can be interesting solutions that leverage SMS and other, low data volume channels. We've put some examples together here for you. On the one hand, on the funding side here, our Ethiopia project, for example, is co-funded by GIZ. Typically where we go into these kinds of efforts, and we're in discussions in Ghana, and working in Liberia, Rwanda, Ethiopia, etc. There's usually that question, but usually the trend is always that the internet access and the availability of devices is naturally improving anyhow because of a lot of efforts. And also in the health side, often you find complementary programs that are going on that are putting more hardware, more connectivity, etc., into these systems, and the device manufacturers, I think, are all interested in kind of mass delivery of their devices anyhow. So I think you can also drive a bargain with many of them and get devices available rather cheaply. Here's some examples. Price ranges of tablets, and you're down to, in Ghana, for example, $115 already. You might have a tablet that a nurse on a ward can share with other nurses, so that these things don't have to be substantial blockers. Certainly if you compare it to the cost of constructing things, or also taking people to things that you have constructed, and the time away from the workforce that implies, etc. So very quickly it becomes a very rational use of funds to make sure that you have that data connectivity and you have that hardware available to that system. And here's an example. Sonia, you dug it out, so maybe you want to say a few more words about how it works.
Yeah, sure. Looking at the SMS and messaging as an option for communication, it's always an interesting way of approaching, especially when we're dealing with a very old hardware and very, very expensive bills for the internet. So I found a couple of examples how Luma Health, for example, is scheduling meetings with its patients, growing tree bank as well, communicating with their clients about specific needs. But the SMS messaging can also be used not just for sheer exchange of information, but also for assessment and receiving back information from the learners or from the clients in this case in particular. So it kind of really offsets the issue of hardware and accessibility of the content, at least via this kind of a simple SMS messaging. And we have a first poll, which actually we can launch.
Go ahead, Sonia.
Okay. I believe you're able to see the question, so I'll read it out loud. How did you offset the issue of hardware in the implementation of your solution, in case you have done so, through financing programs via third parties, discounted prices for smartphones, tablets, or computers, or ensuring operability of the system on multiple devices? We'll give you some time to answer so we get a high response rate. We'll be just a little bit more patient. Currently, we have 38% of response rate. I guess a little bit more would be nice.
Remember, the three of us can't vote, so.
That's true. Or even more. We have also
more,
Charles
exactly.
is here.
So
Yeah.
we may have everybody.
Yeah, indeed. Let's reach 50%. I think we have around 15 participants today. So Okay, I think we can.
I think we're good there. Yeah,
We're good, right?
I think the operability aspect, obviously quite important. Luckily, not that difficult anymore, right? And financing programs are definitely prevalent. You know, in most of our efforts, frankly, it's been a topic of discussion, but we have not yet built in any hardware provision elements in any of the cooperation or funding proposals that we've undertaken, and some of them have been pretty big. To give you an idea of numbers, in Ethiopia, for example, 25 medical schools, over 9,000 active users. We haven't bought a single device for anybody, you know, and then obviously some people might be disadvantaged to not have one, but they can also go to the computer labs in their university if they manage. We have one story. One of our team members is a journalist. He wrote a nice article. Sonia, feel free to post a link there if you like and talk to some of the students. And as I think mentioned earlier, the student was going up the hill, downloading information and then kind of learning with it for a day, going up the hill again. And his dad was paying the mobile subscription, which by local standards was not cheap, but it was important for the family to keep their son studying medicine, you know, and so they did that. And so we haven't had direct funding components of this sort in our efforts so far. Dr. Hoenefer.
Yeah, and you know, the only thing I would add, being sort of in this space and dealing with the day-to-day, is though everyone loves convenience and something that can go with them, and we're all used to our smartphones. In medical education in particular, it's really an effortful endeavor. This isn't something that you casually listen to as you would a movie or a podcast necessarily. And so those students, you know, I think when the institution provides the access and to really sit down and study this content is a very important part of the process. It doesn't diffuse in passively. And so even though the world seeks convenience, we've got to keep in mind the learning science tenet of desirable difficulty and focusing on your work and really structuring a context where they actually learn. So I think that's an important thing to keep in mind. We don't have to make it, you know, available in all settings or on the bus on the way to school or whatnot. If it's campus centered, there's probably some real merit to that.
Well, you might be conducting some summative assessments as well, where you want to know who's doing what. And we did one at the CUGH University in Ethiopia, for example. The system has a proctoring integration with a free proctoring solution called Safe Exam Browser. If you're not familiar with it, it's an interesting one to consider because it's freely available for all the platforms. And it has a Zoom integration as well. And so then, therefore, if you imagine you have a sort of one central Zoom account for the university, you use the Safe Exam Browser. You could even, you know, let the students take their exams at home and instruct them to put a phone next to them. And that would be a pretty inexpensive proctoring avenue, you know. And we also have an integration with a higher end solution, you know, called Proctorio, which would assess my suspicious head movements. And if I kept on looking at a sheet or something like that, that would raise my AI assessed score and high-end things like that. But then you have costs per exams, costs per user, things like that. Still fairly affordable. We're talking, you know, less than $30 a year for unlimited proctoring per student, and definitely under $10. And if you go volume, I think well under $10 to do a formal exam there with the kind of formal AI proctoring, everything recorded and so on and so forth. Depends on how strict your local regulator is. And the local regulator is, I guess, one interesting topic in general for our discussion around the innovation potential. Medicine is highly regulated by definition, and rightly so. But at the same time, the pace of adaptation of the regulations with regards to internet delivery and everything else can obviously also be a substantial hindrance to progress of what's theoretically possible. And I remember when I had my meeting in Addis with the ministry, when we kicked up or, you know, kind of first discussed the idea of working together, I invited somebody from the ministry along, from the Ministry of Education along. Main contact is the Ministry of Health, deliberately because of, you know, planting that seed around the regulatory side early on, you know, and we're in a phase there where we have the foundation laid. Now we can actually start to potentially reconfigure the education system to fuller advantage back to my earlier point around digital foundations alone not achieving the full impact yet. But we're digressing a little bit, hopefully in an interesting manner, but let's go through the technical challenges here and then come to a wider strategic discussion. So on the internet access aspect, this is obviously challenging in many places. And Sanya, I think you're taking that sequence, if I'm not mistaken, right? You want to? No, am I doing it? I'm happy to do it. Okay, sounds good. No problem. So yeah, clearly large divergence there. As you can see, 18% in Africa and only 1 in 10 households. There's obviously a huge degree of variation across Africa as well. We're talking to Rwanda, for example, and they talk about fiber optic broadband into all the clinics and hospitals and so on. I'm not sure exactly what the household percentage is, but there is a fair degree of variation. But again, the mobile aspect, I think, is also transforming that pretty rapidly. Here, if we look at share of users in Africa, you can see that in many of the countries is already very, very significant. And this is the sort of general overall population, once you're talking, young generation, medical, nursing students, it's not likely to be lower, I would think. Maybe in some community health workers or so, when you don't have an income stream that's as high or so, that might vary. But these are promising numbers to build on, in my view, rather than to see them as an obstacle, because if it's not 100%, that's all nice and well. But what do we do for the 60, 70, 80% that have this to make sure we make the overall system more efficient? So that's on this aspect. In terms of the charges also, that can vary a fair bit. I gave the example from Ethiopia. I think that father was paying $10 a month, which for local standards is quite a bit of money, clearly. But there's also a lot of variation here, where you can see in some areas, and quite significant areas, it is pretty developed and affordable. These are the dark green areas here, and expensive here is defined as the share of the monthly income that it would cost to have a mobile internet package. And we can send this around for you afterwards, so you don't have to take notes here or take screenshots or whatever. Obviously, rural versus urban is a key differential there in terms of 28% of households versus 6 in the rural areas. And sometimes, as I mentioned, going up the hill or going up to the local internet cafe might be that extra effort needed to get that connectivity. But also, further points on that. So how do we then kind of address this? One is the mobile apps with offline support. I mentioned earlier, I think, in Ethiopia, in our project there, each of the 25 medical schools has an associated white label app available. And I think we have a screenshot of it coming later in the presentation. And that means that the learners can download things, the faculty can download things. So if there's a power outage or internet outage, they can still do things. And that's obviously quite helpful. Can't put the entire medical degree on there, it would just be too much because we have a lot of videos, but you can then delete things and free up space and do this sort of step by step. Or if you're training a nursing ward on a specific subject, you would make sure the relevant topics are parked on that tablet device. And as you know, these little SIM cards that you can slide into, not SIM cards, but storage cards, flash cards and so on, you can slide into those. Tablets can have many gigabytes already and are pretty affordable. So you can put quite a bit of content there already. Then actually partnering with mobile providers is something we're in conversations of, but my first experience in that being possible is like in Germany. If you're with the Deutsche Telekom, you can listen to Spotify for free on your mobile without the data counting towards your data allowance. They do that to make it attractive. And since it's not video streaming, I don't think the burden on them is that high, but it takes away that concern. If I'm listening on the go, I'm going to use up my data. And so to my mind, if you're doing something regional or national, and it involves community health workers needing to access a tablet or mobile with data connection, why not work with a local mobile operator and get them to make that free or give you a fixed rate for those data packages, and we're trying through the Ministry of Health to have those discussions with the telecom side, etc. I'm not sure we're going to get there, but I think it's worth exploring because from a system standpoint, it makes perfect sense to support the healthcare system. And especially during and after COVID now, I think most governments and telecom providers and so on would readily acknowledge the importance of that and make it happen. There are some additional options, and we'll show you one in a second here. around local Wi-Fi. You know, if you're really, really rural and there is no hope and you would have to go far to get that next signal, etc., you can get data there in different ways. You know, so the first one here is this is on the mobile provider partnerships we mentioned. And this is just some of the, you know, the players here in Ethio Telecom. They're actually owned by the state as well, and so you can hopefully, you know, strong arm some cooperation there if the Minister of Health, for example, is on your side, and then there's certainly various big ones active in Africa here. Some things work with offline support, as we already mentioned, you know, the organizing apps, and even this driving app here works offline. And I've been grateful when I've been driving with apps that continue to work when you're offline, including Google Maps and so on. And here's an interesting one we wanted to share with you. I've had this is not this specific player, but a few years ago I had contact with somebody in India. They were setting up these local Wi-Fi boxes, basically. Also, where you imagine you have the content in a box, and by now it's sort of slimmed down a little bit. You can see what the device looks like here, this Rachel Plus thing. And basically, you can download content blocks onto it. And if that it then sits in your school, even without internet, then, you know, learners can stream it to their devices, you know, which could be devices they brought or devices available in the school, tablets, things like that. Obviously, the same logic is in principle possible in a hospital, where we could also park sets of videos on one of these devices, and they're not expensive, I don't think. And then you could learn locally. You know, the only challenge is, of course, then the information doesn't flow back. You don't get this feedback benefit, etc., that I mentioned. So again, in our own work, we have not touched on these elements in terms of active use of these. But for this, we wanted to look beyond our own work and share ideas and possibilities. And so going offline with Wi-Fi without internet is certainly an interesting thing to consider as well, to quite easily, you know, share information. You can see the number of users you can reach here is reasonably substantial. It doesn't even need power. You could even work on batteries. So if this thing runs on the battery for a while, the tablets have the battery charge, you could operate for a day or two, probably even during a power outage. Yeah, and same question as before to all of you, whether you've had any experience there with the access aspect and what kind of solutions you might have found to those.
I'm launching a poll. Maybe it would be easier to
do. And I'll actually grab a glass of water for myself here in the meantime. So
go ahead. So I'll read the question out loud. Which of the three technical aspects presented the biggest challenge in the implementation of your solution? Delivery systems, hardware, or internet access? And we would be very curious to hear more about your concrete experience. If you feel like talking and unmuting and sharing where you have conducted or implemented your solutions. And we see predominantly, I don't know whether the participants are also able to see, but we have 88% internet access and 13% hardware at the moment.
I think we have to end the poll and share it.
We have to end the poll. Okay, let's give it just 10 more seconds and I'll end it, although we have a huge participation rate. Okay. So this is how the results look like. Again, like I said, internet access 88% and hardware 13%. Would anybody feel comfortable in sharing a little bit about your experience, where you have implemented your solutions and why internet was such an issue?
I've worked for the Department of Veteran Affairs within healthcare. And so the lack of hardware and seeking approval for the appropriate funding from contracts for AT&T, T-Mobile, and Verizon. So it set a limitation for those iPads that were needed through hospitals and inside clinics, as well as mobile devices. They removed some kind of like the contracts with the iPads and distributed to a different department, but they were trying to take away those because those needed a lot more data for those.
And
Thank you
can I
for
ask,
sharing.
was the intervention a cloud-based intervention, or did
Yeah.
it require apps installed on the devices?
So apps, they use the ServiceNow app and then Epic Healthcare app for their system tracking. But the issue was everybody wanted an iPhone. That's the problem. People didn't want to share. People hate sharing, and especially during COVID, no one wants to share, and no one wants to look over at someone's shoulder. They want their own. So everyone did not get approval, and you had to have a valid justification to obtain a device.
Interesting. And your target audience was?
Doctors, social workers, nurses, anyone throughout the veteran affairs.
Interesting. And were they allowed to use private devices? Presumably.
No, you have your policies. People, I can tell but people do what they want, but they are allowed. That was a big thing of people utilizing their own devices and installing those applications, but that interface of that application could get a little sticky.
Yeah, interesting. Yeah, because obviously those, I think, is an interesting aspect in what I was referring to earlier in terms of leapfrogging in Africa. I think people are often much more willing to be pragmatic and get on with things, and you can see that how certain policies could create substantial blockers for progress, and and depending on the setting, one might use those or not, depending on the target. But thank you for sharing, very helpful. And Dr. Hoenefer, please.
Yeah, and I can add just from personal experience and build on that. There are a lot of intricacies and technicalities with respect to actually delivering internet access, at least to the medical schools that I've been working with. And in both cases, actually, in Samoa and in rural Jamaica, both schools had a fiber optic internet connection immediately available, something I don't have at my home in Maryland, interestingly. So, but to connect that to the school and distribute it accordingly was a significant effort in both places. And most recently in Jamaica, it took us almost 2 years to get the configuration of the routers, and I really can't speak to this from a technical standpoint, but we had local IT, we were dependent on local IT support, and had one gentleman working on this for a prolonged period of time, and it just wasn't working out, and finally replaced him, found someone else who solved the issue in very short order. So it's not just a matter of supply, but it's a matter of local expertise in configuring the systems and making them operable. So that was an interesting experience. It just, you can have the pipe right nearby, but if it isn't properly configured, that can be very problematic. And perhaps having expertise to share widely would help solve this problem in many places. So.
Thank you, Dr. Hoenefer. So yeah, let me continue and share my screen again with you. And so on the content aspect now, we touched on it already a bit before. Let me go full screen again here. Oh. So on content creation and curation, you also have to bear in mind the digital literacy challenge. So for example, now Sanya is right in that process, we're looking at health extension workers in Ethiopia, doing some data analytics training and things for that, like that. And so both the literacy in terms of scientific concepts and everything else, as well as the digital literacy might vary for your target audience. And sometimes, therefore, to keep it really simple is important, because if you throw a highly capable but very complex system at them, you might lose them quite easily. And so something to bear in mind as you're using things, bear in mind any copyright issues. Not everything you grab off the internet and screenshot is okay to share. On our end, we create most of our illustrations, but we have a partnership with Elsevier, for example. They use some of our videos. We get to use all of the illustrations, and but things to bear in mind, and think about what are effective formats. So for our health extension worker training, for example, the ministry shared some 160-page PDF training files with us for family medicine and maternal planning and things like that. And they were just, I mean, even I, after 5 pages, would struggle to concentrate, very little illustration, very dense text, etc. So depending on your target audience, engaging formats like videos, we have dual coding, auditive and visual stimuli for the brain that will help make information enter much more easily, And then finally, think about that point we had earlier around the quality of the feedback loops and the tracking of what you push out, because the data generated by that will really make sure that you have an actual intervention, and some concrete examples on that. If we think about the reality on COVID and how it's been, a lot of information has been sitting in these public pools. We have some content of ours, for example, in the Africa CDC platform as well. You can see some screenshots here. The challenge there is you don't have this, you rely then on your system at the bottom, the different learners that you have to go and pull this information. You don't really know what happened. And therefore, back to our earlier point around these dedicated systems being really valuable, where somebody can control these, can leverage, because the WHO is happy to give any government or region or state or city the contents to put into their systems. But then once you control the local system, you can add your own content to it and so on and so forth. You can also upload your learners to it. You can then push the content to them, and you get that important feedback loop working. So, and we're more than happy if you have specific setup somewhere where you're trying to support somewhere. We had, Mary Nelson here, you kindly shared about your efforts in rehabilitation in Ghana and Ethiopia and so on. We're more than happy to see what contents we have that could help you. And if you don't have a delivery system, give you a delivery system to sort of enable that controlled local implementation. In terms of our library, I think I shared a little bit already earlier when I jumped into the platform. So we believe videos in being a very useful delivery format for any layer of health worker training. As I said earlier, we have about 10,000 of them. So we're used to producing a lot of these, and then also co-creating them with the local audiences for what makes sense. As I had already mentioned as well. We also, which is then very nice in terms of, the required bandwidth, have complete textbook chapters, about 1,500 of those. And that also makes a very useful reinforcement on the reading side of things. We often in our delivery start with a video and then the text is reinforcement. But obviously, you can focus on the text first if you don't have so much bandwidth, and the video might be tricky to get through whatever bandwidth you have. And here another example for this co-creation of local content. Here you see a patient monitor, happens to be a Chinese model that is actually quite prevalent there. And therefore the instructor is from the local college, local technical college in Addis, the oldest one, founded in the 50s. And we then co-create these contents together with them and assist in the production, illustration, etc. Another thing I'll mention, which is part of the leapfrog opportunity to our mind, it's not just bringing more online into the learning delivery, which obviously has massive potential in terms of making it more scalable, make it more affordable, make it reach the rural areas better. But our fundamental belief also is that medicine is an evidence-based science, but much of the teaching is not that evidence-based. And one of the things we know is that we all forget things, and things like spaced retrieval algorithms can be very powerful in working towards more long-term mastery-oriented learning approaches, but they're not hard to put into practice because you need the contents, the algorithms and everything else. So in our system, the learner, this is an individual learner view here, they get their daily deck in terms of what questions and topics should they review today based on their own learning history, when they last saw which concept, how accurately they answered the quiz question associated with the concept, and what their confidence levels were at the time. So it's a fairly elaborate algorithm and very hard to replicate that pointed personalized, adaptive kind of delivery of content and reminders without a platform. You know, it would be very hard to preach and tell students or faculty, you know, that's a really good idea. You should review everything at the right time and in a really granular way, but how would you organize for that? On the right-hand side, you can see then the mastery level. That means as you've reviewed these items up to 5 times or from 5 times onwards, in essence, they start to enter your long-term memory. And therefore, you know, now you're at mastery level and you might not need to review this again, but this doesn't happen if you do it 5 times in a day or 5 times in a week and you kind of cram it, but it happens through this spaced increasing time frames type of repetition. And this is what the system tries to facilitate. And that's a whole different leapfrog. You know, if you think about how we structure our education systems, usually it's for these summative assessment points, and a lot of cramming before that, and then a lot of forgetting called the Ebbinghaus curve after. And with this kind of approach, hopefully you can start at a much higher level. You might still do a summative assessment and do some reviewing, but you also continue at a much higher level afterwards. And that's the whole idea of the design there in terms of platform design. On the content side, and Dr. Hornhofer, I'll let you add, and then we have a question for the audience again here. What content pools have you found that you found useful that you might want to make us aware of? Because I'm sure we have not seen the full world out there, given how big and dynamic that world is. Dr. Hornhofer, you first, though, please.
No, I was just going to build on that, and an excellent point, and something that you may not immediately recognize, but the whole platform and the power of this platform-based delivery is to leverage evidence-based strategies that have been shown effective, mostly by our cognitive science colleagues, of which many of you probably recognize that spaced repetition is one, but Stefan alluded to the advantages of dual coding through our video presentations, and we really try to adhere to recognized and evidence-based principles in multimedia. Many of you may recognize the name of Richard Mayer, and we really focus on applying the science in all of the aspects of what we do in this type of platform delivery. And that's something that's not easy to instill in a conventional educational concept or framework. And so things like interleaving and spacing, which can be so reinforcing and so helpful, can be much more readily applied. And in my experience, lastly, many of the students in underserved areas do not have rich academic backgrounds and really haven't mastered, don't have natural abilities. So I'm a huge advocate, as Stefan knows, of emphasizing the importance of implementing these strategies. And that's not just in underserved settings, but in the best universities as well. I wish I had been I had been familiar with these strategies when I was in medical school. It would have made my job much easier. So it's important globally at every level. So thank you for bringing this up, Stefan.
Thank you for adding to it, Dr. Hornhofer. And so, yeah, back to the audience questions here. And I don't know if we have a poll for this, Sonia, or not.
This one, no, but the following, we have a question.
So any content sources that anyone has come across that you would like to share with us? I think the CUGH website has a content source section, somebody called iPhone needs to leave, and that's okay. Thank you for joining us. Appreciate you have some patient care coming up there. But anything anyone has found that they feel is worth sharing in terms of content sources?
Yeah, I have more of a question about the content. Do your medical education consoles offer a variety of clinical use cases relevant to the individual communities in Africa?
When you say clinical use cases, you mean sort of patient scenario questions, a little bit like I showed you, or what do you have in mind when you say use case?
Both, what you just
said.
Said.
Right?
Sure.
Yeah. So as I shared earlier on these clinical case questions, definitely when it comes to the health extension workers, for example, and the trainings we develop there, they're fairly thoughtful in terms of creating local personas and things like that, family constellations, different kinds of people that reflect the reality there, to try and really, make it, how should I say, relevant and fitting for the local community. So it's back to that same localization question. It's obviously easiest done when you're building something from scratch, like we're doing there. Then you're working in the local system to start with. And then when you start with something that exists, it's that gap analysis, modification analysis, like I mentioned earlier, also, for example, with taking existing cases, duplicating them, adjusting them, or adding to them. Frankly, we haven't in the Ethiopian context. It was interesting because we built this local, into the project, we built this production that we showed some samples of already for equipment use and maintenance. And we also had planned to let's create some locally relevant content in addition. And interestingly enough, from the educators in the medical schools, there was less perceived need of that. They felt like, okay, it's just so useful to have so much ready-made content that we can map to our curriculum that we can get on with. There was less appetite than we expected to add to it. That doesn't say it doesn't make sense. They obviously got a lot of utility and content and functionality at the same time. And so maybe they're just digesting that and enjoying that. But that was just one concrete experience there. In Liberia, it's also similar. We're open to co-producing content there, but they're mainly using the existing content.
I can add to that with my own personal experience. When I was teaching at the Children's Hospital in Columbus, Ohio, and I was teaching medical students, I involved them in forming use cases. We started from scratch. I would pose, let's say, a case. And again, this was fictional. I would pose a case that existed in a small community in some place in Ohio. And I would ask them to pick the community. And then we would start from scratch, say if we were building a case about complex pneumonia in an 8-year-old child. I would pose, what kind of tests they would recommend. I would say, okay, what are the results? And then we would discuss those, and then we would keep building the case itself. So they were actively participating in building the use case.
And I think Dr. Hornefer let you comment, but I know he's a big fan of your approach in terms of letting the students co-create the materials and cases and so on.
And I think that's very much the future. I'll allude to that in a bit when I talk as to what's coming. But again, that's very evidence-based, and we know what works from a learning science perspective. So that's absolutely true. Good. And I'm keen to get to the part, actually, Dr. Hornefer, where we let you talk about your concrete experience there. Much of what's coming here now, we've already shared more or less. So in terms of our Ethiopia project, here you can see a little map of the different medical schools that are operating our platform with that mapped local curriculum on it, and where we do continuous training. There's always a change management aspect with any technology introduction. Just dumping it on a system alone is not sufficient. Is that localization on the one hand, but then really empowering them to use it and showing them how the data can assist in their teaching. So that one of the features of the platform is that it creates a lot of data. I showed you briefly, if some of you joined later, but each video has these quiz questions associated. And from an educator standpoint, this continuous formative assessment for every 5 minutes of learning time spent by any of the students, and assessment both of the competence as they answer the question correctly or incorrectly, but also of their confidence. And so that's a very rich data stream. So therefore we spend time with the educators showing them those things, showing them how they can use that to focus their teaching. They could potentially give credits for this and so on. And as I hinted earlier, they could also incentivize things like compliance with the spaced repetition algorithm, which would be a completely new kind of incentivization
of the learner. So we spent time going through these things. Most of the things here, I think we've already mentioned, about 9,000 students plus. We had set a goal of 8,000. So we're pleased to have exceeded that despite the natural obstacles in general in terms of accessibility and so on that we discussed at some length. But also you might be aware there were, kind of significant political disruptions and some unfortunate violence and conflict still going on to a degree. But despite all that, we were able to reach all of these learners and engage them and assist them in their studies, and you can see on the left here an example for one of the apps. This is Addis Ababa, one of the largest universities there, next to St. Paul's, and on the right hand side, this mapped curriculum and also some of the equipment types that we're producing content for there. And I think you saw that earlier screenshot, our team on the top right, you can see the kinds of illustrations our designers create, and then we co-create the actual video training, in this case for maintenance. He's going to take that whole machine apart in the video and so on. And we do the post-production editing, etc., to create some high-value, useful things there. And now, Dr. Hornefer, over to you, to your very unique experience. I was very impressed when I first heard about it, especially the timing of it when Dr. Hornefer did what he did there, and kind of shows what's been possible in medical education for some time, but where COVID maybe has finally opened the minds to make more of this as a reality, because I think the challenges in Africa we're unlikely going to meet unless we innovate in terms of delivery methodology. So Dr. Hornefer, do you want me to click through or just hand over the sharing to you?
I think why don't I try and share it, and if there's a problem, I'll give it back to you and make sure I get the right screen here. And
perhaps I'll read up the question. We have one question from one of the participants. How do you overcome barriers in a culture of medical education whereby the focus is more on memorization of teaching content, and due to this aversion or fear to digitization? I see this in the rural communities. Any guidance?
Mm-hmm. And it's an interesting question. I think Dr. Hornefer has some interesting things to say about that, because I think some of his students in Jamaica may not be that different in terms of initial inclinations. And Dr. June, thank you for joining us. Glad you could. But Dr. Hornefer, please go ahead.
Yeah, and this is absolutely on point, and one of the great challenges we face. But I have to share with you that it's a challenge in various underserved areas. It's also a challenge in the US and many universities. The education community has been very comfortable doing, we all taught the way we were taught, and not the way the evidence guided. And so we are in the midst, I believe, of a great cultural transformation. And I also believe the pandemic will help move things along. So to go back a little bit, and I'll address this with my comments, but when I became involved with the project, which was conceived originally to bring medical education to the island nation of Samoa in the South Pacific, where their students typically were sent to New Zealand or Australia for education, and sometimes and more often than not did not want to come back because they saw the brave new world and opportunities. And so Samoa was remarkably underserved, and a visionary and philanthropist had the idea of using the internet to provide education and bring it in remotely and couple that with on-site clinical services, but also realize that there were students, people that wanted to get medical degrees that either financially or for a variety of reasons couldn't go through the conventional system, and wanted the school curriculum available globally. And for time zone purposes, the school, we had students in Australia, New Zealand, and also the United States. in that there was enough time difference to facilitate. These were all synchronous lectures that were brought in. And just to put it in context, there was a huge undersupply. The island nation of 300,000, I had 8 or 9 physicians and even very few nurses, which made access very hard and limited. As I mentioned a few minutes ago, they did have a fiber optic connection, quite remarkably, and this allowed us to get faculty, and they ended up ultimately being based in part because I was situated in the United States, and many faculty offered to teach in their evenings, which was the Samoa morning and early afternoon, and brought in the didactic component in live synchronous lectures and coupled that with on-site experiences. And we essentially deputized the few physicians that were interested in this project, and it was supported by the Prime Minister, who is also quite visionary. And this was successful. Now, I have to say that there were clear challenges in terms of culture, and at the time we were doing mostly classic didactic presentations, PowerPoints, online exams, and it was often hard to get a sufficient number of students to amass the large body of knowledge that you need to be a competent physician. But indeed, it was successful, ultimately got accredited, and we had graduates not only for the Pacific Islands, but in Australia, New Zealand, and fully licensed physicians in the US. So I think this was the first hybrid online medical school model, at least that I'm aware of, to gain accreditation. But as I alluded to, the inefficiencies of having to rely on synchronous presentations and the like left me, for one, energized. I thought this was just an amazing idea, but also convinced that we needed a unifying platform, that much as every school that creates all its own curriculum and its own methods is inherently inefficient. And if you can think about, just by analogy, the automobile industry, that at one point all automobiles were manufactured in local mechanic shops. And it was really not until mass production and cars were widely produced that you could have quality. And this has been demonstrated again and again in food and service and in multiple industries. And I think the time has come now to keep this concept in mind in terms of the delivery of medical education. And so I left well, actually, I want to mention one other thing of note in Samoa, which was very interesting and not entirely unexpected. But as we as effectively deputized the local physicians to help with teaching, it not only provided education for the students, but as you can imagine, when you have to teach something, you make sure you know what you're teaching. And I entered this whole realm after 20 years. I started in academics and then ended up with a group heavily focused and almost exclusively, not quite, in practice. And it's very easy to become complacent and not be at the cutting edge. But when you have residents and students asking you questions, what we found is that the level of expertise and knowledge of our faculty that were locally based also increased. And I think that that's very empowering. You don't just come in to create doctors, but to create centers of medical education. I remember Samoa had a particular problem with rheumatic heart disease, and there would be efforts from grants and from out of the public health sector to come in and try and re-educate. And for the 2-3 years that those programs would run, there would be an acknowledgement of the risks of not treating strep throat and having folks susceptible to rheumatic heart disease. And then these programs would end and people would slip back into their former cultures and not attending to medical needs. So the idea here is to build local educational centers with external didactic support. You're not going to get the biochemists, the pathophysiologists, the various experts to teach all these subjects and move to places like Samoa, but you can bring those resources in and couple it with the local personnel. So I thought that was also a lesson that I learned and a very powerful part of disseminating medical education. So I then went to find an ed tech partner that had a global perspective and could help create a didactic platform. I was also interested in new ways to teach and learn, because I felt that for many of the students in this environment, they needed a lot of help. And exactly to the question that is raised, how do you change that culture? And we're smack in the middle of that process. I have ideas that I'll share with you that I'm using. And so I really have two hats that I wear almost equally. They're both both are fascinating endeavors, and so my work at Lecturio is complemented by the opportunity I have to help shape and create a school that was established in rural Jamaica. It's government chartered and has access, therefore, to the government hospital systems and a rich array of clinical volume. But the idea is to create physicians for the country of Jamaica, and in particular to help bolster this very underserved rural area in the town of Black River on the southwest coast. It's called the All-American Institute of Medical Sciences. It was actually founded by an immigrant surgeon or a physician who immigrated from India to Jamaica and did his residency and realized that there was a great need not only for physicians, but initially for technicians in ancillary services, dialysis techs, phlebotomists, respiratory techs, and opened evening schools to train these people. And these evening schools were very successful, and took the next bold step to establish his own medical school, and understood that digital resources would be a key part of making this successful. And so this is a picture of me. Immediately to my left or to the right on your screen is Dr. Chalasani, the founder. And actually, when I joined, this was the entire faculty of the entire basic science faculty, not the clinical faculty of the school, which was putting students through successfully. And really the main way they could do this is with a platform-based approach. And I'll address that shortly, but to give you an idea of our pedagogical design, the idea is to bring in content experts, and we have synchronous teaching, but we rely heavily on the library. And so Lecturio was already in place at Ames before I was introduced, or actually the founder reached out to me, knew of what I'd done in the South Pacific. I thought initially he wanted help integrating Lecturio, but he really needed more leadership and guidance, as the former local leadership in Jamaica didn't understand really all the ways to implement the technology. So the key elements are to have remote content experts, both for synchronous teaching and highly curated content, video sources. We couple that with on-campus student coaches. You have to have a presence, and my experiences in Samoa with the students in Australia, New Zealand, and the US showed me that there are, a good number of individuals that have the personal discipline to focus on their studies and set other day-to-day distractions aside, but many can't. And so
Do we?
Looks like
these
Peter's
wouldn't be-
connection. Peter,
Sorry?
you were hanging for 10 seconds, for 5 seconds there. So let you
sorry
continue
about
now.
that. Well, as I say, it's not just the third world that has connection problems. If you lose me, then so my apologies. But so on-campus oversight and guidance is crucially important. We also leverage education specialists. These are folks with experience in instructional design and pedagogy to help guide both faculty and these mentors and coaches, because being evidence-based both in the strategies implemented and the delivery systems is absolutely key. And so my last point is that evidence-based teaching and learning, utilizing proven strategies from learning science is key to success. And if you have all these elements together, we've made a lot of progress in helping the students acquire the knowledge that they have and change their behaviors. So just to show you one other aspect of what we've done, because we have a variety of student capabilities, is move to a mastery-based modular curriculum. Before I arrived, it was a very traditional system of semesters, roughly half the year, and students progressed, with their classes. But many of the students would fall behind, and others wanted to accelerate. So we divided the first year with the foundations year subjects into these modular blocks. And you have to complete all of the requisite module blocks to move from the first year, which actually now we're going to be calling phase one, so that they don't feel like they're being left behind. But the average student is envisioned to take 4 of these courses, and we're on a quarter system, so that if they have to repeat something, they're not a half year behind. We have 10 or 11 year quarters. But students that only feel up to taking two courses in a quarter can do that, and they simply have to complete these elements or master them to move on. And that has been hugely helpful, because in the prior system, students that had to remediate would do so while still progressing with their class. And so the weakest students had the heaviest loads, and it really made no sense. So the second year is an integrated approach after they've mastered the fundamentals in each of the core sciences. And we take a systems-based approach. This again leverages learning science, where it builds in spacing and interleaving. And we go through each of the body systems. And at the end of quarter 8, or the second year, they then will go on, they will have 4 to 6 weeks to review for their boards. We use the international version of the US exam, the USMLE you may be familiar with, but the national boards that curates the USMLE creates an exam, the IFOM, which is the International Foundation exam. And it actually comes in two parts, one for basic sciences and one for clinical. And it has more of a global nomogram, but we require an external source. Our top students actually occasionally elect to take the USMLE, and every year we have some of our students that do well in those exams and actually want to get further training in the US. And we've been very fortunate that they've matched and gone on to training, even though all our graduates are guaranteed training in Jamaica. The third and fourth year are much more traditional, though they still have access to the lectorial platform. Excuse me, to the lectorial platform and are supported didactically across multiple clinical settings. So even though they get an excellent hands-on clinical training where there may be gaps in the didactic presentations, that's again provided through the platform. So this is just a quick snapshot. The last year ending in early March. And you can see just over that year, these are the video lessons that the students, and it's divided up by course, but 100,000 lessons. There's no way that our small faculty could have produced that extensive collection of didactic presentations. And they have this vast array of recall questions. And Stefan's shown you the spaced rep deck and all these learning science features. One thing he didn't point out that I'm a big fan of, and it's hard to get utilization, but at the end of every video, they get an opportunity to perform a brain dump. And those of you who are cognitive science fans, and I love the term, but the idea is not to take notes during the lesson, but to see what you can retain from it and write it down. And actually this continuous improvement to the platform. And we're now adding capabilities where students and faculty but can add their own materials, and hopefully ultimately this will come in, we'll be able to integrate these into spaced repetition type algorithms. So we're really looking to re-envision how medical education is delivered, to democratize its availability. The faculty that contribute to the lectorial platform come from top universities around the world. And it's not just that they're in universities, but they're targeted because they really professors who really were much busier in research. And I learned a lot more from their graduate students than from them as teachers, and others were fabulous teachers. And I think not everybody is inclined to teach and shouldn't teach, and there's a real art to teaching. So I think we need to re-envision just who teaches how and how that very valuable resource is disseminated. So I think Stefan actually showed you the video of this earlier, wonderful illustrations when we're teaching physical skills in this case. We have mapped learning objectives, which are associated with all the videos, and then there are recall questions that follow. So this follows sort of the key tenets of instructional design. I will mention that I also host a near monthly global seminar which reviews topics from learning science and how to apply them. And we have a great audience, typically from 60 or 70 countries, that participate, and we often have 300 to 500 medical educators on a regular basis. And that's one of our efforts to really help people understand that there are important new ways to teach. And not only is it more effective, but as this slide alludes to, and frankly, the pandemic proved in spades, we are constantly faced with instability. I actually, when I arrived at Ames, everything was paper and pencil based, classic, final exams, in-class lectures. And I did not have the foresight to predict the pandemic, but I was very concerned that a tsunami or a hurricane, or there would be an environmental disruption, and proceeded to digitize the exams, to put everything online. I was remote. I visited frequently, but I was having Zoom meetings. We were actually at Ames, had a full digital presence by the end of 2019, which, as the pandemic hit, was fortuitous. We were the only school in the country that didn't close. And I have to say, when you're absent, there are all these rumors that float around. And I found out afterwards that one of the senior faculty, who had not been very happy about moving everything online, was telling people that I had unleashed the COVID virus to prove that they had to be digital, that there was merit to this. But thank goodness nobody believed that. But there are, beyond the effectiveness, beyond the ability to deliver, I think the resiliency of being platform centric. So I think what you see on the right is the future of medical education. And there'll still be buildings, and it's still important to congregate, but I think we need to rethink how we're teaching and learning. So just to summarize, I really believe we're in the dawn of a transformational process in education, that platform-based learning will be the new gold standard. It allows you to do many things that are clearly demonstrated as effective within learning science, in particular, the flipped classroom. And the flipped classroom it has all sorts of connotations, because it creates a void in class that nobody really knows what to do with. And so my other little anecdotal story about Ames is that as I initially tried to introduce this concept, the other thing that was going around campus was that our dean has flipped, trying to propose this. But in fact, it is gaining in momentum, and we have several faculty using an approach where the didactics are delivered ahead of time. And again, it's greatly facilitated by being able to have not only stock content, but adding your own content to a platform and leaving you free in class to have discussions, to have quizzes. Some faculty do in-class Jeopardy sessions. If those of you that are not familiar to the TV show, it's a knowledge retrieval show. Can you answer certain questions, and you get points for it. There's team-based learning. There are all sorts of things you can do inside of a flipped classroom. And in those institutions that have adopted this approach, it ultimately is appreciated by both faculty and students. And along those lines, we're going to be moving from passive to interactive learning, and gaming is going to be a key part of this. Our teachers are going to turn more into coaches and mentors and motivators. Doesn't minimize the importance of the direct instruction and didactic component, but it needn't use faculty resources to give a lecture in a live synchronous fashion. We know that no more than 10% of that content is retained. Person-to-person interaction is very much augmented in this model, not diminished, even when it's delivered remotely. And this provides for increased effectiveness, availability, and affordability. It's much more affordable to create schools. So we're going to be moving from, I believe, lockstep progression to this mastery-directed learning model that I've just described. We won't teach by historical precedent. We'll be taught by what the data demonstrates is effective. And that's really the evolution that I've witnessed over the last 50 years in my involvement in medicine, that it's become increasingly data-driven, certainly in my specialty in heart surgery, but I think we've all seen this in the careful evaluation of vaccines before they were released. And the other important area is how we use testing, that we really need to use testing increasingly as a diagnostic and learning tool, not just to assign rank. And as Stefan alluded to earlier, the use of computers to evaluate the results of exams and help guide both students and faculty will be very important. And so with these new approaches, we're going to be to recap, what's the future hold? I think mastery-directed learning. I think teaching and learning beyond university walls. I think we will have, as I did in the Samoa-based project, students in many continents. And actually, I had a student that actually enrolled at Ames, was going to travel from Denmark to be part of our school, given its innovative approach, but was trapped in Denmark due to the pandemic and completed her first 2 years remotely. She's now moved to campus, but I think there's going to be more and more blurring of the lines of where students are, as long as they're carefully supervised. There are also new opportunities in continuing education involved in perpetual alumni community. When you're connected through a platform that you're not physically located in, why couldn't your graduates continue to be involved in your educational processes, irrespective of where they go? Wiki authoring, teachers as editors. I alluded to the importance of having an editorial function, but this allows students to contribute to a platform and then have the teachers serve as editors. We often encourage, and many of our faculty ask the students to write their own exam questions. Tuition reduction is an advantage in that you can do things far more cost effectively, as auto, retail, all these other industries have understood that sharing resources does allow for great cost effectiveness, and our tuition is a fraction at our school at Ames that of many other schools, even in the Caribbean. And the vastly improved access, I think, has been addressed and is fairly intuitive. And I want to sort of conclude with one last plea, and I think this would be commonly felt, is that I think we have lost, as educators, control in many instances of what our students are doing. And I think that there really is an important role for a school, but it's very important that the educators control the process, that they pick the platforms, that they oversee the process. None of what I suggest displaces the faculty or the school construct. I am not in any way an advocate for go out and teach yourself. I think we have a lot to contribute in guiding our students, but we need to curate the sources. All their textbooks, and Lecturio has the video formats and the concept pages, and the learning science methodology built in. And my contention is that if you know everything in those two platforms and you get good clinical training on site, that's an in-person part of this methodology, that you will be an outstanding physician. When students go into all sorts of resources and dabble in this and dabble in that, I think they get distracted and they don't do, you know, the hard and important work of actually learning. So you need to give them, you need to curate, define the tools they need, and do your best. I mean, obviously I can't keep them from using other tools, but we strongly encourage them to use those tools. And I have my faculty limit all their didactics specifically, you know, and the content side to those tools, not that they can't refer to other sources and bring them in, but that the work of studying be shared. And actually we provide all this at the school level free to all students. So they all have equal access to their resources. They don't have to pay for textbooks. Technology improves the effectiveness and availability of medical education. And we have to shape how this technology is used. So these are my key takeaways from really the last 12, almost 15 years now in this area, and still working hard to make this work. So anyway, that's my experiential overview. And so thanks for having me participate in this.
Well, thanks, Dr. Horneffer. And, I think your experience there is absolutely unique globally, as far as I'm aware. Obviously, there's more of these things happening now. But as I said earlier, and I was very impressed, you got all this done and accredited back in 2010, or maybe accreditation in 2011. I don't remember exactly. But either way, that's, I think, very pioneering, was well ahead of its time. And some of you have stuck around for the full length of this, and it's gone almost the 3 hours, which I didn't think almost we would fill. So, and John, you've been pretty active, but Caroline, Julia, and Dr. Davis, we'd love to hear from you as well, and take the chance to hear also specifically about, since we're talking capacity building, do you have specific areas, project area, subject areas where you have a specific interest, where we could maybe collaborate, support you in some manner, et cetera, or, any learnings you want to share from efforts you've made there. And so let's do a little round. I would say we've done so much talking from this end with some interjections and engagement, which is great. But Caroline, maybe do you want to start? Carolyn, I think, if I'm pronouncing it correctly, Dr. Charles. Or Dr. Vandenberg or Dr. Davis, just unmute yourself, and it'd be lovely to hear you and see you.
Hello, I'm actually not a doctor. I'm here just to listen today, but this has been the most interesting session, so thank you so much.
You're very welcome. And what's your background and interest?
I'm an analyst. Most of my background's been in the pharmaceutical space, working in commercial drug development. But recently I joined an NGO, and we're working in education and global medical support. So I logged onto this session today, and I've learned so much.
Excellent. And what's the NGO, if I can ask, Julia?
Brothers Brother Foundation. It's a really small NGO in Pittsburgh.
And what do you focus on in terms of the capacity building or education side of things?
So right now we mainly work in short-dated pharmaceutical distribution to organizations in need of kind of like basic medical supplies, but we're looking to expand beyond that. And so that's what I'm working on now.
Got you. And, any of those topics obviously always have, we're just doing cold chain management content for Ethiopia, for example, and obviously that has logistics aspects as well, not usually complicated. Well, somewhat complicated, maybe more complicated in pharma when it comes to the cold part, depending on what you're distributing. But which geographies are you active in there, if I can ask?
Yeah, so we work mostly in Central and South America at the moment. But we also, we have kind of a grant program as well. And so we're trying to figure out how to best allocate those funds And yeah, we're basically just kind of doing a revamp of our strategy and looking at like what can really lead to sustainable development and what are kind of the major trends. So that's why I signed on to this conference.
Got you. Well, if you have any specific training needs there, so on the one hand, we have a lot of pharmacology content. We have a lot of foundational content, biochemistry, and these kinds of things as well. And if you want to support the kinds of things that you're doing there, i.e. the distribution and how to do that well, and you want anything custom produced, we can do this for very small budgets or help you deliver even freely, potentially, if you're small and you don't have much funding. We're always interested in seeing new kinds of use cases. So if you're, for example, producing a voiceover PowerPoint that explains how certain things work on your end and stuff like that, we can upload that to the platform, add quiz questions to it. That way you can track the comprehension and confidence of the people that are doing these things, and might help foster the overall goals that you have there. So more than happy to have that kind of conversation if it's helpful.
Yeah, definitely. I'm really interested in this. So I'll connect with you on LinkedIn. We'll keep in touch that way.
Good. Yeah, sounds good. And
Thank you. Oh, sorry.
Go ahead.
Oh, no, I just wanted to say thank you to everyone. The information was abundant, actually, to say the least. It was, to throw that in there, it was overwhelming of information that I even want to rethink my research, because I set the limitation of just the US and not worldwide. And so taking that, you forget about the other side of the world, because you live in what you know. And of course, I haven't visited every state, but I can relate better to the United States than other countries. With that being said, I have a lot to take back. Will this recording be accessible in the future?
So yeah, so CUGH are organizing all of this, and so absolutely, I think this should be made available as part of their standard proceedings there on the CUGH website. And then remind me what the focus of your research is, topic-wise, Takila?
The lack of healthcare technology or artificial intelligence within rural and urban communities.
Yeah, you mentioned that at the outset, right? Right. Yeah, exactly. And as I said, I think this rural community challenge is quite interesting, and it's not quite a guide training that we're doing there at the moment in Ethiopia, but it's on fundamental use of data and teaching health extension workers.
And that's what's lacking.
Things, and that's, I think, interesting as well in the rural area.
Absolutely.
Right? So, what's the prevalence? What's the percentage change? Even at some of those basic levels, if you do it with concrete examples, you can potentially add some value there, right? So,
but I would add too, in that part of my practice is in a very rural setting, and there is a bottleneck in terms of training both medical students clinically in the US and at the residency level. And often the pushback is from having to deliver the didactic component. So if you can support the process, the clinical materials, it's really the same idea that we started in Samoa, that there are patients and doctors everywhere, but it's the education piece that we need to bring in and help support. But if you can do that, you can leverage the local healthcare delivery for the hands-on much more widely. There'd be many, many places that you could train people if you augmented the didactic piece. So the Samoa model applies from my perspective in Western Maryland, or wherever you are, just as well, in that context.
Thank you. That was a lot to write.
Thank you so much for sticking with us. And Dr. Rosenfield, go ahead if you have any final comments.
Yes, I wanted to add to Peter's presentation, which I was thoroughly impressed with. Just a personal experience during my own education, a medical education in the early 1970s at Ohio State University. There was a experimental program that allowed one to use a platform-based education of biochemistry versus a traditional lecture-based program. And I chose the platform-based. And it turned out that that area of biochemistry, that turned out to be my highest score on my Part 1 national boards. So what Peter has said about platform-based education being the future, I'm actually very supportive of. And I do think that the areas of interest that I have in interpersonal development of infants can be platform-based. I'm going to be publishing sometime in 2025 or 26 a series of books about that. I've been working on it for just about 10 years, and I look forward to more talks like this that you've presented.
Well, thank you very much. And I'm going to quickly tell for Stefan, everybody, I probably need to move to Jamaica quickly because I'm struggling with my internet here today. And if I disappear, it's not that I'm out of energy, but all that being said, I think it's really important as we implement this, that the success is a combination of the technology and the platform and the on-ground configuration. You can't just throw this out there and have it used, much as these evidence-based learning strategies can't just simply be described. And a big part of our effort now is learning how to change the expectations, the paradigm, and support users appropriately. So this is very much a work in progress, and we need as much input and help and support from people like yourself and others who are interested in promoting this concept.
Excellent. I'm very impressed that you got the highest score there. So yeah, it does show the promise, right? Because everything becomes very clearly structured, and yeah, the algorithmic intelligence in on top. We should absolutely create more and more evidence of the actual outcomes being better on these things. And Dr. Rosenfield, I obviously expect a video on your research findings once you're there. It'll be a good way to publicize your book, and then let's see how it can help disseminate all of these things. Excellent. And Charles, I think you were just patiently sticking around doing the tech support here, if I'm not mistaken, right? Or oh no, that's the Convex. No, so we got Carolyn. Carolyn, did you want to share as well? Sorry, I wasn't sure because it was the same name there appearing. And you'd have to unmute, but no obligation. Good. Well, it's been a pleasure to interact with all of you and work up and share our thoughts. For us, this was an interesting exercise as well to gather some of the things that we gathered there. So it was learning in some ways for us as well, because we weren't giving you a marketing pitch presentation, but really trying to reflect on these challenges and different kinds of solutions and things like that, and even found some things that we hadn't seen before. So we hope some of it was helpful. Obviously, will be available through CUGH, and we thank all of you for not making it lonely for us to take it through here to almost the full length, so as scheduled. I think the next time we'll aim for a little shorter, but the time has passed fast, despite having been substantial for me at least. So, and thank you, Sonia, for organizing everything. Thank you, Dr. Hornefer, for joining us, sharing all your experience. And with this, unless anybody else has any final comments or thoughts, then I would adjourn the session.